And it gives me a lot of pleasure to introduce Amandeep Shergill, and she's joining us for the first time as a speaker from UCSF and the San Francisco VA. And she has expertise in endoscopy and in IBD, and in recent years, actually, she's extended her expertise into a very important field for us as GIs, which is ergonomics. And so I'm looking forward, I think we all are looking forward to learning about how we can better take care of ourselves. Thanks, Amandeep.
I want to thank Eric and the Society for inviting me to speak today. Let's see if I can figure out how to make this work. Okay, by way of disclosures, I do have a Pentax research gift on ergonomics. So over the next half hour or so, what I'd like to do is to give you a broad overview of ergonomics, evaluate risk factors that are associated with repetitive strain injury and how that is applied to GI endoscopy, review potential ergonomic interventions, as well as what might happen if an injury were to occur. So to give you a little bit of background, I became interested in ergonomics when I was a first-year GI fellow. So a fellow who was 1 year ahead of me in the GI fellowship program had actually decided to leave GI and to go into radiology. I had done residency with her, and she was one of the smartest people that I knew, and so I was asking myself, what does she know that I don't? And you just have to take one look at the endoscope, or put the endoscope in your hand to know that we can do better than this. And so that's where ergonomics comes in. What I hope to impress upon you is that we really can do better, but in order to do that, we need to take us as the users into account when designing the scope. So ergonomics is the study of how work affects people physically and cognitively, and it quantifies human capabilities and limitations and then applies it to work so that you are creating jobs to fit individuals instead of forcing individuals to fit into jobs. And so an example would be this deboning knife at a poultry facility, where initially they were just using a regular chef's knife in order to debone chickens and turkeys. And there was a very high incidence of carpal tunnel syndrome, a very high number of work-related complaints and premiums that were being paid out for workers' compensation. And after an ergonomic evaluation, they were able to develop a new type of knife with a pistol shape that allowed for neutral postures while holding the knife, allowed for better and more effective force application. And this was immediately led to happier workers, improved efficiencies on the line, decreased time required to debone poultry, increased profits, decreased workers' compensation, saving this company over $500,000 in workers' compensation premiums over the years. And so truthfully, good ergonomics just makes sense. And two important concepts in ergonomics that are unfortunately critically missing in the current endoscope design are the concepts of anthropometry and biomechanics. So anthropometry is the study of human dimensions. It's understanding what the hand size, body size of the smallest 5th percentile female is, the largest 95th percentile male is, and then designing a tool or a job site that can accommodate the full breadth of users. So standard design criteria really requires that a job or a tool be efficiently and effectively and easily used by that 5th percentile female through that 95th percentile male. Biomechanics is how the body produces force and generates movement, and muscle force is influenced by two main things. So one is the length-tension relationship of a muscle, and if we all remember back to medical school and those actin and myosin filaments, you get maximum overlap of your actin and myosin filaments when you're in your neutral postures. So neutral postures is our position of greatest strength. And we're always going to want to work in our neutral postures, and any tool or job site that we use should ideally allow us to work in our neutral postures. The second thing that influences muscle force is sheer muscle mass, and this is unfortunately where women are at a significant disadvantage. So gender is the most important predictor of strength, and men are stronger than women in all age groups. So men have, on average, about 20 pounds more muscle mass than women do, and women, on average, have about 60% of the strength that men do. Women at their strongest in terms of pinch and grip strength are strongest in their 20s, and in our 20s, we are equally as strong as men between 70 to 80 years of age. And I don't know many 70 or 80-year-old men who are still scoping. If you do, please let me know. Even more concerning in studies that have been done that have looked at, is there a pointer on here? Yeah. Okay. So in this study that looked at grip and pinch force, what it was unfortunately demonstrated is that 95% of women are weaker than 90% of men. And even our most elite female athletes women who their job in sports requires them to have the strongest hand forces. Even our most elite female athletes only achieve the pinch and grip strength of the 25th percentile male. So again, women here are at a significant disadvantage. And so what happens is not only are we at a biomechanical disadvantage, but the anthropometrics have not been taken into consideration. So in one study of GI fellows, it found that fellows with a small hand size, less than 6.5 glove size, mostly women, had significant difficulty sort of holding and manipulating the scope and felt that their hand size inhibited their ability to learn endoscopy. And so what happens with work-related musculoskeletal disorders is if there is this mismatch because of poor design, considerations that did not include anthropometric or biomechanical considerations, external loads such as holding or manipulating the scope in our general work environment, depending upon the forces that are required, how long those forces are required, and how repetitively we may be performing these tasks, can then exceed the internal tissue tolerances. And when those internal tissue tolerances are exceeded, we can get pain. That pain is a result of micro tears or micro trauma to either the tendons, ligaments, or muscles. And over time, if we continue to work through that pain, thinking that it'll get better on its own, that can lead to these work-related musculoskeletal disorders. There is strong evidence for a causal relationship between physical work factors such as posture, repetition, and high force, and work-related musculoskeletal disorders, specifically in the neck. It's non-neutral postures, in the shoulders, non-neutral postures, as well as in the back. For the distal upper extremity, so your carpal tunnel, the wrist tendonitis, and the elbows, it's a combination of posture, repetition, and force. So what happens in the early stages of a work-related musculoskeletal disorder is there may be aching and tiredness of the affected limb. It occurs during the work shift but seems to disappear at night and during days off, and there's really no reduction in work performance. But in the intermediate stages, that aching and tiredness occur earlier in the work shift, they persist at night, and there can be a reduced capacity for repetitive work. In the late stages, aching, fatigue, and weakness persist at rest. There may be an inability to sleep and to perform light duties, and that can be associated with significant disability. And there have been now multiple survey-based studies that have established a high prevalence of injury in endoscopists. So on the low end, 37% of endoscopists, and on the high end, up to 89% of endoscopists responding to these various surveys, reporting that they have experienced some injury which they perceive to be related to endoscopy. And so our group really sought to understand these biomechanical risk factors as they apply to endoscopy. So if you think about it, we're holding these scopes oftentimes for, depending upon the procedure, an EGD, maybe 10 minutes, a colonoscopy, somewhere between half an hour to an hour. So there's sustained static loads of the scope, definitely repetition to our day, potentially high forces, potentially awkward joint postures. So what we sought to do was to understand what are the loads on the distal upper extremity, and do those loads exceed safe thresholds of risk? So in the ergonomic literatures, there's established thresholds, for instance, for the muscles of the distal upper extremity, for work such as the endoscope where you have light work that has frequent pauses. As long as you're working below 30% of your maximum voluntary contraction, that's considered to be generally a safe threshold. You're not going to get injury at that level. But if you go above 30% of your maximum voluntary contraction, if that's more forces required to manipulate your tools, then you're at potential risk for a work-related injury. We looked at pinch forces, and in the ergonomic literature, the established risk for pinch forces is 10 newtons, or about 2.2 pounds of force. So if you're repeatedly using 10 newtons or 2.2 pounds of force, that's been associated with the development of carpal tunnel syndrome. And more recently, in prospective studies, percent of time in high pinch force, so if you're spending more than 11% of your time in a work cycle in this greater than 10 Newton pinch force, that's now been prospectively associated with the development of risk disorders, including carpal tunnel syndrome. And then lastly, we looked at joint postures, and specifically any non-neutral posture is going to put patients at risk, or put us at risk. Specifically, though, we used a threshold that has been demonstrated to increase carpal tunnel pressures. So when we gathered this data and we looked at it in terms of these thresholds, so we looked at left colon insertion, right colon insertion, withdrawal, and retroflexion, that during all phases of colonoscopy for our left wrist extensors, we are exceeding that 30% maximum voluntary contraction threshold, and actually for left colon insertion, approaching 50% of our maximum voluntary contraction when we're manipulating that endoscope. We have non-neutral postures when we are holding the scope, and both the right and the left wrist are predominantly in extension. When we looked at that 10 Newton threshold, both the left thumb and the right thumb during all phases of colonoscopy exceed that 10 Newton threshold of risk. And specifically, when we look at percent time spent in that high pinch force, the left thumb certainly, but the right thumb, almost a third of our time is spent in high pinch forces, exceeding that threshold of risk. So performing colonoscopy is work, and the question is, how can ergonomics help? So I've given this talk a few times now, and when I've given this talk, I've really focused on what the endoscopist can do in terms of trying to achieve neutral postures, both with manipulating the scope as well as in the endoscopy suite. But I want to provide a little bit of perspective, and that's in ergonomics. When we talk about exposure control, the most effective exposure control is defined here through this hierarchy of controls, and we as the endoscopist, the end user, we're at the bottom of an upside down pyramid. We are the least effective interventions that can be made to control exposures. And so the most effective interventions are going to be either elimination or substitution of the hazard. Next is going to be engineering controls, isolating people from the hazard. Then administrative controls, changing the way we work. And lastly, that's where we as the endoscopist might come into play. So elimination is really the idea of prevention through design. So prevention through design is a safety concept that aims to lower risk for workers by eliminating or reducing hazards as early as possible in the life cycle of equipment. And early ergonomics truly does reduce costs. So in the design process versus in the development process, it's going to be 10 times more to correct any kind of problems, but after deployment, almost 100 times more. Substitution is replacing the hazard, so new technologies are certainly being evaluated. They may obviate the need for us to maneuver the colonoscope through the colon, for instance. They can be self-propelled, self-navigating, potentially using alternate methods of manipulating, such as guiding by a joystick. But any device substitution needs to be rigorously evaluated to ensure that other unintended exposures are not occurring as a result of the intervention. Really what we're left with practically being able to apply in our endoscopy suites are engineering controls, and this will be both at the level of the operator-tool interaction as well as the operator-work environment interaction. And so when we think about, is there anything that can enhance our interaction with the tool? So there is a right-left dial adapter that's available by both major endoscope companies. And it works basically by clicking right onto that right-left dial, and in theory can make that right-left dial more accessible for small hands, as well as can optimize the grip for larger hands as well. This has not been systematically studied. There was only one abstract study that was published many years ago, presented at DW many years ago, and it found that while it really didn't improve procedure or overall ease of the procedure during the small study, people who were using it did feel that retroflexion was easier to perform with that dial in place. Anecdotally, though, folks who do use this and have incorporated this into their practice do find significant benefit from it. So there's a significant static load to just holding that scope. Can we alleviate that load and in some way reduce exposures that way? So a few years ago, we had presented results of an anti-gravity support arm that did seem to reduce that left extensor loads, but because of the way the prototype device was set up, it actually led to increased left wrist extension while holding the scope. So again, highlighting the importance of needing to study intervention to make sure that unintended consequences aren't resulting. Most recently, we presented our results of the Pentax scope stand. So this is not yet available in the US, but we evaluated on a simulator whether or not there was any reduction in left wrist left extensor loads. And interestingly, not only did we see a reduction in left wrist extensor loads, but we saw some differences and decreases on the right side as well. So by potentially making the control section a little bit more easier to hold and maybe a little bit more access to the dials, that actually changes how the right hand was scoping as well. Anything that decreases cecal intubation time or procedure time that decreases our exposures can potentially be helpful. So something to think about is CAP-assisted colonoscopy. So CAPs have been shown in a Cochrane review to decrease cecal intubation time. And most recently, there was a study published by Doug Rex on the endocuff, which not only decreased cecal intubation time and overall procedure time, but showed no reduction and maybe even an increase in adenoma detection rate. So again, thinking about tools that are going to decrease our exposure to colonoscopy overall may be helpful. The work environment is critical, and this is something that we do hopefully have some control over. Sometimes it does require us to get administrative buy-in, but neutralizing our postures before we start a procedure is critical to ensure that, again, we're working in our position of maximum strength. And so that monitor really does need to be right in front of us, at or below eye height, and that bed needs to be just below elbow height in order for the body to attain a neutral position. So if there's one picture you take home with you today, in your mind, I want it to be this: what happens when that monitor is too high? You can see here that even slight cervical extension is going to lead to problems in that cervical spine. So in order to optimize your monitor height, you have to think about where that resting eye angle is. So your resting eye angle is about 15 to 25 degrees below the horizon. And so your eyes, when you think about where they're going to rest on the screen, you want that middle of the screen just below your eye height to allow for your eyes to be in a resting position as well. So in order to accommodate the 5th percentile female to the 95th percentile male, you really do need adjustable monitors in order to be able to accomplish that. And the viewing distance is going to depend to a large degree on the size of the monitor as well as the individual endoscopist's preference, but that monitor should be adjustable to between 93 to 162 centimeters in order to accommodate those breadth of potential users. Similarly, for the bed height, it should be at or below elbow height, 0 to 10 centimeters below the elbow. This is extrapolated from the laparoscopy literature, but the idea is if the bed is too low, you will be flexed forward, and that will lead to strain on the back. If the bed is too high, your shoulders will be abducted, and that will lead to shoulder strain. So you want to think of the bed position that's going to allow you to hold both the control section and the insertion tube with your shoulders, elbows, and back in a neutral position. So administrative controls are controls that change the way we work. And so some examples of administrative controls might be scheduled endoscope maintenance, ergonomic education, as well as design of the workday. So scheduled maintenance is key, but unfortunately right now only one endoscope company is recommending proactive endoscopic maintenance. We know that exposures to the biomechanical risk factors are high even when the endoscopes are performing at the manufacturer recommended specifications, and that over time the responsiveness of the control section dials may decrease. More force may be required to turn the dials to achieve a comparable or potentially even lesser degree of tip deflection. And angulation repairs are one of the most common types of endoscope repairs. So again, we have our scopes on lease, and we're able, if something doesn't feel right, to send it back to the endoscope companies. You may not have that luxury if your scopes aren't on lease, but that's always something to consider. Only one of the endoscope companies right now recommends that after 100 procedures or so, you send your scope back so that they can get reevaluated, but this is certainly something to talk to your endoscope representative about. Ergonomic education is sort of key, such as like in venues like these. If you are at a large hospital, most large hospitals do have ergonomists on staff, and so it's important if you are feeling any discomfort, any pain, you feel like your unit could be improved, to consider a formal ergonomic evaluation. Certainly any changes that are implemented, it's important to involve all staff because nurses and technicians are your allies. And getting good habits early on is also critical, so trying to incorporate ergonomic training and fellowship curriculum is important. I had the privilege of working with a group of doctors to create the ASGE Ergonomic Learning Libraries DVD on ergonomics, and so that is available through the ASGE, and there are some other resources available online. Ideally, you pre-procedure are incorporating an ergonomic timeout. So the same way you do a timeout for the patient to ensure it's the right patient, the right procedure, and you're ensuring your patient's safety, you need to ensure your safety before you start a case. So take those few seconds, and it really is just a few seconds, to make sure that you've put that monitor at the right height for you, that monitor is right in front of you, that you've tried to get that bed height so that when you're starting out, you're trying to neutralize your postures as much as possible. It's just a few seconds, but we don't know when we go in there necessarily how long that scope's going to take, and you're optimizing yourself from the outset. I get this question often: is there an optimal endoscopy schedule? Unfortunately, there have been a lot of studies that have been published, but all the studies that have been published to date have looked at operator fatigue, but at patient-related outcomes such as adenoma detection rate, and whether or not endoscopist fatigue leads to any decrease in adenoma detection rates. There have been no studies that have been done specifically looking at what might be an optimal schedule for an endoscopist. The only advice I can give here is that it's best to never start your second day of endoscopy in the week still recovering from your first day of endoscopy from the week. So if you do develop pain or have discomfort at the end of an endoscopy day, making sure that you've given yourself sufficient time to rest and recover before your next scheduled endoscopy day. So that might be maybe a Monday morning and the next one a Tuesday afternoon or a Wednesday. Half days may be better than full days, again, just to give your body time to rest and recover in between cases. But it's important not to start your next endo day if you're still having pain from the prior session. So personal protective equipment, this would be what's left at the discretion of the endoscopist to use. So OSHA states that using personal protective equipment is often essential, but it is generally the last line of defense after engineering controls, work practices, and administrative controls have been implemented. But unfortunately, oftentimes this is all we're left with. So one thing we potentially have control over is our technique, and there is no optimal technique, but in England, for instance, they teach all endoscopists to hold the scope one way. So the control section is held horizontally, and with the umbilical cord, if it's on the outside of the wrist, the idea is that the weight of the control section is perfectly balanced, and then they're using their larger muscles, such as the biceps, to result in tip deflection there. So you can see that they're not pinching or gripping that insertion tube. Instead, they're harnessing the large muscles of the biceps and resulting in tip deflection that way. So there may be ways for us to utilize our larger muscle groups instead of the smaller muscle groups in order to result in manipulation of the endoscope. So this is one technique to consider. So currently in Canada as well, they have train the trainers courses, and this is where this technique is taught. I first learned of this technique when I went to an ASGE, World Endoscopy Organization, train the trainers course. There's multiple of these courses that happen throughout the year, so something to consider. There is another school of thought on optimal technique or optimal holding of the scope, and that's that the umbilical cord should be held on the inside of the wrist because that allows for maximal access to the right-left dial. I personally find that if the umbilical cord is draped in front of my wrist, that I've lost a lot of degrees of freedom. I cannot reach that right-left dial, so I'm doing a lot of torquing, and I do move the control section around quite a bit to get additional tip deflection. So I personally don't use this technique, but this is another technique to consider. The important thing is it has to be comfortable for you. I think many of us figure out a way to hold the endoscope, but if you're finding that your technique is resulting in some kind of pain or some discomfort, what is it during endoscopy that's resulting in that pain and discomfort? Is there an alternate technique that you could utilize that may reduce that exposure? So can exercise help? The data are really mixed, and in ergonomics in general, we don't like to say that people should be working out in order to be able to do a job because that really pushes the burden onto the physician or to the worker, and that's not where that burden of fixing a problem belongs. Right now, we believe that there's not enough evidence from scientific literature to guide policy or practice, but it certainly does make good sense that we should be, as much as possible, trying to stay healthy. In a Cochrane review from 2013, ergonomic interventions reduced pain in the long term, but exercise made no difference. And in one systematic review, stretching had a moderate level of evidence, especially related to computer work, and resistance training had a strong level of evidence if it was implemented as a workplace-based resistance training exercise policy. It's important for us to figure out ways to rest. In the ASGE survey that had been published a few years ago, almost a quarter of endoscopists don't take any rest at all. So during the procedure, trying to figure out a way to alternate your position, use assistance if possible, consider the implementation of micro breaks, which we'll talk about in a second. And so here, even just setting down the endoscope on the patient to rest helps to alleviate some of that static load of the scope. And post-procedure, thinking of ways to, when you're completing the documentation, to really just give those muscles that we're working out during the endoscopy a chance to rest. So the problem with static postures are you have a increased need for blood flow because the muscle is contracted, but the blood can't get in because of the contraction. And that's as compared to dynamic postures where you have an increased blood requirement, but because you're moving around, the blood flow matches the blood requirement. So you want to figure out ways to convert your static postures to more dynamic postures. So that would be potentially utilizing a footrest or low stool, anti-fatigue mats or cushioned insoles. The way these work is they actually induce postural instability, and so because you're unstable, you're moving around, and because you're moving around, you're contracting your muscles. And that way you're beginning to pay some of that lactic acid debt back before the end of the procedure. Compression stockings actually have a good level of evidence to support their use in improving symptoms of leg fatigue. And again, this idea of implementing mini breaks or micro breaks. So there was a multi-center study that was done in a cohort of surgeons where in the middle of an operation, they would step back from the operating table. They never broke sterile protocol, but they would do a series of exercises, neck exercises, wrist exercises, shoulder exercises, and they found that for this group of surgeons that pain scores improved for almost every anatomic region, and that most of the surgeons were going to implement these targeted stretches throughout their operation days and were able to do so without showing any increase in operation time. So this is certainly something to consider if you find that you're particularly tired by the end of the day. In our ASGE DVD, again, I had the pleasure of working with Dr. Raju and Nao Kuzusaki, who is a Houston ballerina, on a series of post-procedure stretching exercises that can be implemented right after your endoscopy, and it sort of utilizes the things that we were doing within the endo unit, even just washing our hands, to reactivate our core muscles, to stretch out the muscles that were used during the procedure. And so this can be found again on the ASGE DVD. So I've gone through a few of these controls, and it may be, though, that you implement and do everything that I talked about here today, and that you still develop pain, still develop a potential injury. And again, the reason is because in terms of effectiveness of controls, what we really need is endoscope redesign. And unfortunately, in order to do that, that's something that's out of our hands. That's something that we need buy-in from the endoscope companies for. But it's critically important for these endoscope companies to understand and to take into account we as the end users in this process because of our high risk of injury due to the high risk of exposures when performing endoscopy. And so I wanted to take the last few minutes to talk about what happens when an injury occurs. So when you are feeling pain, we need to respect pain because pain is that first sign that something is going on in our tissues. When we experience pain, it's because the local tissue damage has occurred. We've exceeded the thresholds, the internal thresholds of the tissue. You're getting now inflammation, cellular activation, and matrix repair. And if we give adequate time for rest, for repair to happen, then you can get functional tissue repair and sort of get back to your baseline. But if we don't give adequate time to rest and repair, and especially if homeostasis is not achieved, then there's this vicious cycle of damage and fibrotic repair that happens. And so here is an image of what normal tendons look like, and this is what happens when you get a tendinopathy or a tendinosis. Tendon healing creates more collagen fibrils and less mature crosslinks with stress. During the remodeling phase, there's going to be a relative period of weakness before full remodeling occurs, and then the degeneration, if it sets in, can become this tendinosis. And tendinosis is very common, both particularly in sports, but as endoscopists, the muscle groups that we're using, many of these injuries will be related to overuse tendinosis, so it's very common. The time for recovery, if you present early, can be 6 to 10 weeks, but for full recovery for a chronic presentation can be anywhere from 3 to 6 months. The likelihood of a full recovery, and this is extrapolated from the sport literature from chronic symptoms, is about 80%, and the focus of conservative therapy is encouragement of collagen synthesis, maturation, and strengthening. So really, in order for tendons to properly heal, they need about 100 days to synthesize collagen. Initially, you're going to have an inflammatory process, then a reparative or proliferation phase, then remodeling, first consolidation, and then maturation. A mild injury will take 2 to 4 weeks, a moderate injury 4 to 6 weeks, and a severe injury 6 to 12 weeks or potentially even longer. If we have effective repair, then we can get back to normal strength. The tendon itself will get back to almost normal architecture and elasticity. However, if there is poor repair or tissue scarring, then it's not as strong. It actually gets thicker, is less functional, and less elastic. And so here is an ultrasound image on the right of a normal tendon, and on the left, what happens when the tendon didn't properly repair. You can see that it's thicker and that it doesn't seem to have that same structure as a normal tendon does here on the right. And so it's really important to think about that road to recovery if you have pain. So one, respect pain, and then once that pain sets in, we have to modify our activity. So what are we doing that's leading to the pain? What subtask within performing endoscopy is leading to this issue? And what do we need to do to try and isolate that exposure so that we can minimize our risk of further injury? This is going to require reducing stress or biomechanical deloading. So again, trying to figure out ways, neutralize postures, minimize forces. Importantly, physical therapy will be involved, Physical therapy for both stretching as well as strengthening of the tissue. Pain control, this is something certainly to do in conjunction with either your occupational medicine physician or your orthopedic surgeon. There's variable literature about the role and the benefit of both NSAIDs as well as steroid injections, so finding out where that fits for your particular injury will be a discussion with the doctor who's helping to treat you. And more, there's newer therapies that are coming out that may induce healing. I want to take just a few minutes to talk about the importance of disability insurance, because I think that we just don't talk about this as much, and this is so critically important to what we do, especially given our potential high risk for exposures and injury. So the best time to get disability insurance is when you don't need it. So the young fellows in the room, when you first get out into practice, this is certainly something to consider and make sure that you're optimizing your disability insurance at the outset. So disability insurance is going to replace a portion of your income, somewhere between 50 to 70%, when you're unable to work due to injury or illness. And so it's important to speak with, and ideally you are getting the help of someone within this field, so an expert to help guide you through this. But short-term versus long-term disability. In GI, it's probably important to consider own occupation disability. So there is the potential of having any occupation disability, which means that if you have to be able to do you have to not be able to do any work within medicine before you'd be considered to be disabled. As gastroenterologist, we want own occupation, because if we can't scope, that's going to significantly affect our salaries. There are lots of different riders that are available, and so this is just a small list of them, but partial or residual disability benefit will pay benefits in the event of a partial loss of income. So for instance, if you're in private practice and it's a eat what you kill model where you only take home the actual number, the amount of procedures that you performed and money associated with that, if you have an injury and you can go back to work, but you can't quite do the same number of procedures that you did beforehand, you are going to have a decrease in your income. And so this partial or residual disability benefit will help bridge that gap. So something to consider, especially for those of you in private practice. A future increase option allows you to apply for additional disability insurance coverage regardless of health as your income rises. So again, when you are young and if you have the option of having this future increase option, then when you hit 40 and 45, as your income grows, you'll have the ability to increase your coverage without having to undergo another health examination or physical examination. There's also a potential cost of living adjustment rider that you can consider. And all of these things, once you have it, you don't necessarily need to have it for the full time that that you have the disability insurance available to you. You can get rid of the riders if you don't need them anymore. But something like the future increase option may only be available early on. So in summary, the risk of injury is real. There is a high prevalence of endoscopist injury based on these survey-based studies, and we've been able to document high-risk exposures through our biomechanical risk studies. We can do some things for exposure control, but think of that hierarchy of controls as endoscopists. We're on the bottom of an upside-down pyramid, and we really need to be telling our endoscope companies that they need to do better and take us into account when they're designing our tools. When an injury occurs, it's important to plan out your road to recovery so that you can gain full function back. And I can't stress enough the importance of disability insurance. Thank you.